first one means danger. The second one means opportunity. Okay? And what opportunities occur will depend on what the outcome of that crisis might be. What I want to talk about is crisis intervention and what nurses and other healthcare professionals can do to assist people in crisis to cope. Sometimes your interventions need to be very creative. Sometimes need to be very, very flexible in order to help these people in crisis situations. Now, one of the things that we saw this fall is that a lot of times there are factors that limit people's ability to cope of stressful life events. I mean, mental illness and substance abuse and poor history of coping skills. Other things, diminished cognitive abilities, pre-existing physical problems, limited social support networks, and developmental physical challenges. How many of you saw patients when you were caring with people with this fall, whenever they were admitted to the hospital, that they had no family, they may have been homeless, that they had no financial support, okay, or they had a severe mental illness that basically impeded their problem-solving abilities, and how do I cope with that? The way that they respond to crisis often was with anger, and what that did is that got them into further problems with the law or with their family. They alienated their family and lost that social support that they needed. You know, and it's one of the things that I talk about with my clinical group is there, but by the grace of God go I, because we have those coping skills. We have that family support, and a lot of these patients did not. What you see is that crisis is a sudden event that disturbs homeostasis. That sometimes what happens is our usual coping mechanisms cannot resolve the problem. Things that we have tried in the past don't work in this particular situation. And sometimes we're at a loss to figure out what we can do to get through this situation. With characteristics, basically they're very personal by nature. What you find is that what one person considers a crisis, another person may not. And what happens is that if that friend that is your support system doesn't see this as a crisis, then how supportive are they going to be? I mean, God, it was just a dog. I mean, yeah, but it's a dog that I had whenever I was 4 years old, and it's basically kept me sane until I'm now 20 years old. Okay? So, if that person does not consider it a crisis, the support that that person often needs is not there. Typically with crisis, what you're talking about is an acute stressful situation. Typically with an acute stress response, it's resolved within a very brief period of time. Typically what we see is 1 to 3 weeks. Okay? Either the crisis is resolved, it goes away because coping mechanisms were developed, or it goes away because the person cannot deal with it, and they have done something like commit suicide. Basically, that crisis situation contains both the potential for psychological growth and psychological deterioration. And we saw that with a lot of our patients this fall, because what may have happened is that a sudden impact on their lives precipitated an exacerbation of their mental illness symptoms. Okay? They began using substances again, or abusing substances. Or they checked themselves into the hospital because I just can't deal with it. Often what you find is that with crisis situations, that individuals feel helpless to make changes. They don't have or don't believe they have the resources to deal with the stressors. And sometimes what you find is those thoughts become fairly obsessional. That's all they can think about. What am I going to do? What am I going to do? What am I going to do? And they have behaviors that are aimed at relieving the anxiety. And they can reach panic levels. What is one of the ways that they can decrease their anxiety? Drugs, alcohol, or avoiding the situation. If I don't deal with it, it goes away. Well, that's a coping skill sometimes that can be successful because, remember that old saying, don't sweat the small stuff?
Don't sweat the big stuff.
Huh?
Don't cut the sweaty stuff and don't sweat the big stuff.
I like that better. Alright, don't sweat the small stuff, and just remember the majority of it is small stuff. But the thing that you have to, I'm getting tickled. The thing you have to remember is that to this person, this is not something small. To this person, this is a major impact on their lives. It's just like the joke, you know, what the difference between major surgery and minor surgery is? Major surgery is when it's done to me. Minor surgery is when it's done to you. Okay? Think about that with crises. Okay? What we see here is that sometimes with response, whether or not they respond to a crisis or in a stressful situation depends on three factors. The individual's perception of that event. If it's, well, that's no big deal, then they use that coping mechanism and go on. What are the supports? Do I have friends? Do I have family? Do I have a nurse that will tune me into the social worker? And the available of adequate coping mechanisms. Okay, if drugs and alcohol are your coping mechanisms, then that probably is not going to have a favorable outcome in a lot of situations. Now, there are three types of crises: maturational, situational, and adventitious. Maturational crises are dear old friends Erikson and Piaget, or Piggott, for those of you that... Piaget and Erikson basically say that each age group has a crisis. And we develop coping skills in each of those maturational crises to overcome them. If you do not successfully meet the challenges of that age group, what is it going to do to the challenges you're going to face in that next one? Okay, you're going to be sort of stuck in this back here. In other words, if you don't develop the social skills in order to develop a peer group, then the next stage when you're learning or trying to develop a relationship, a close, intimate relationship with someone that will be your significant other, you will have difficulties. Okay, so maturational crises. One of the things you need to remember with maturational crises is that typically the coping skills that you develop in the lower levels do not work for the upper levels. Each set of maturational crises, you have to develop a different set of coping skills. It's just like when that 4 or 5-year-old goes into the hospital. What typically occurs with those folks? They repress or regress, okay? And they begin bedwetting. Bedwetting doesn't work for a 32-year-old.
They think it does.
It will basically you'll sleep alone if you wet in the bed at 32. Situational crises. Okay, remember we've just talked about motor vehicle crashes or multi-system trauma. Those are the situations that may provoke a crisis. For example, if the person that's the breadwinner was the victim of that accident, it may provoke a crisis for the entire family. It's just like when Ernest Grant was talking about the burn victim, okay, where wife and picked up kids and moved to Chapel Hill because this person was going to be in the burn center for probably 6 to 9 months. Well, what you typically find is that, like he said, employers are usually pretty lenient 1 to 2 weeks. But after that, often you find that they're not quite so lenient. Well, how many months are you going to be out? Well, I can understand that they need to have someone in that position. But think of the crisis that would, not only the illness and the trauma, so to speak, of not only the patient, but the family will undergo, but the financial and the social relationship crises that may occur. Now, adventitious would be disasters. Floods, tornadoes, storms, whatever, where you may have a lot of people that are displaced or undergoing a similar crisis. Now, what's the difference between this type of crisis and the previous two? They're not alone. Well, yeah, they got a support group. But what usually is going to happen to the resources?
Mass resources.
Yeah, there's a mass loss of resources. Whereas someone with a situational crisis after a motor vehicle accident may have been able to get tuned into some community resources for funding and for home care. If the entire community is wiped out, those resources are gone for everyone. Alright, so looking at phases of crisis, phase 1, you're confronted by the conflict that threatens self-concept, and they respond with increased anxiety. The second phase, the usual defensive response fails, and then if that threat persists, then anxiety is going to escalate. Trial and error begins. In other words, everything I have tried so far hasn't worked. So they use like a shotgun approach. Well, sometimes what you hope is that you're going to hit on the right thing. But typically what happens is that you try multiple things with no good response, so you try something else. Sometimes you don't give that option long enough to work. Sometimes what you find is that it doesn't work because you don't have the resources there. Typically, if trial and error attempts, anxiety continues to escalate and panic sets in. If that problem is not resolved and your coping skills effective, then that person can be overwhelmed. And what we worry about is it can lead to serious illness, and this is where we need to be aware that we need to be assessing this patient for suicidal ideations or homicidal ideations. Crisis intervention is what we as healthcare professionals will be doing. Again, very flexible sometimes with our resources. Now, if you look at these situations from a theoretical standpoint, basically what you would do is there's 7 stages in Robert's model. Okay? I wouldn't be so concerned about knowing which stage is what, but just know that you need to identify this is what happens once they're tuned in to the healthcare system. Our basic is going to be assessment for suicidal ideations or homicidal ideations. That's why we have that 72-hour hold for harm to self or others. Okay? Establishing rapport. A lot of times what you will see with these crisis situations is they need a support system. And establishment of that rapport will go a long way. One of the things that you need to help them do is to identify what the problem is, or what was the last straw, or what caused this crisis to occur. It's sort of like you don't want a mama fix it, okay? Because if mama fixes it every time, what's going to happen to that patient? They don't develop the coping skills necessary to deal with this crisis the next time. So what do? Come back to mama and mama fixes it. Okay? They need to identify what that problem was. They need to deal with their feelings and emotions. They need to generate and explore alternatives. That's why when we have patients that come in with drug or alcohol problems, if they want rehab, they're given a list of the rehab agencies, and they are the ones that have to make the appointment. They are the ones that have to get the follow-up. They are the ones that are going to have to deal with this problem. Because if I call and make you an appointment, how committed am I as that patient to getting to that appointment? I'm committed as the nurse getting you there. But if you don't have that commitment to follow through with that appointment, then that's going to happen, sort of a vicious circle. Okay? Lastly, develop and formulate that action plan. And then hopefully that crisis will resolve. And then you need, as a healthcare provider, to do some follow-up. Okay? The role of the nurse. Our phase 1 is going to be assessment. We're going to do assessment of this patient to figure out what the precipitating stressor and the resulting crisis that prompted them to do professional help. Really, one of the things that we need to remember is, again, what's stressful or causes this crisis to one person may not seem like a crisis to us. And we need to look at it through the eyes of that patient. What is that individual's perception? What is that family's perception? Now, I'm not saying that sometimes that perception is totally off the wall. What we need to do is to help them get more back to a reality base. But you need to recognize that this problem is very, very real to them. The more clearly that problem can be defined, the better chance to find an effective solution. And these are some of the questions that you're going to ask. How are you feeling? How does it affect your life? What's upsetting you the last few days or weeks? Looking at that level of anxiety is very important. And that magic question, have you thought of killing yourself or anyone else, is one of the things that you need to do. Because remember, with this crisis, this very poor coping skill, suicide may seem like the easiest way out. Some other guidelines. Well, we want to find out, do they need inpatient hospitalization and treatment? Well, if they answer yes to that magic question, I've thought of killing myself or killing someone else, then that's the magic 72-hour question. What's our follow-up question to that magic question? Do you have a plan? Do you have the availability of your plan is your question number 3. What are your usual coping skills? Drugs or alcohol? Those are not effective ways. On a long-term basis, they work every once in a while. But if they're used as the only coping mechanism, that's something you need to make sure that you don't do. Phase 2, therapeutic intervention. One of the things that we want to make sure that we do is to select the appropriate nursing diagnoses. Taking into the account the type of crisis. Is it a maturational? Is it an adventitious? Is it a situational crisis? Taking into account the strengths and available resources. And these are some of the nursing diagnoses that you may come up with. Risk for self-directed violence, powerlessness and hopelessness, probably up there on the top of the list with your patients in panic. Sleep deprivation, risk for loneliness, rape trauma syndrome, dysfunctional breathing, chronic sorrow. Remembering all of these nursing diagnoses need to develop a plan of care. And that is what our third phase is. What are your interventions? That will depend on what your nursing diagnosis is, and it will depend on the situation that that patient is in. Basically, one of the things we're starting to see is that a problem-solving model becomes more of a basis for change. And remember that problem-solving model, the focus needs to be on that patient developing the problem-solving skills. If you solve the problem for them, then they have not developed the skills. It's sort of like the parable with you give a man a fish, he eats for a day. You teach a man to fish, and he eats for a lifetime. You need to teach them these coping skills. Intervention. The focus of the problem is on the here and now. What do I need to do right now to decrease that patient's panic level? What do I need to do now to help them to understand what the problem really is? What are their true feelings about that? Other things that you're going to want to do. What are some strategies that you can do to change that are realistically possible? What are some alternative coping strategies? What are some of the coping strategies that we want to teach patients that undergo crisis? Well, I've already mentioned problem solving. I'm sorry? Prevention, yeah. I mean, one of the things that you will see is that if you know that you have a psychiatric illness that has to be treated with medications, you take your meds. You know that you have anxiety in certain situations, like PTSD, that we're going to talk about in a little bit, that you seek treatment. Prevention works very well. What's some other methods that you might want to teach them?
Relaxation techniques.
I'm sorry?
Relaxation
techniques, definitely. We're going to talk about that when we talk about PTSD. The other things, of course, are remember that a lot of these people need to remember is they're not in it alone. They need to seek social support. Or what you need to do is to seek assistance early before you've reached that panic stage. So early intervention. One of the main things you need to teach them, though, is how do I recognize that I'm getting anxious? One of those oh shit moments. What do I need to do to calm myself down? How am I going to cope with this? Again, those coping mechanisms are very highly individualized. That choice must be made by that patient. Looking at me is just evaluation of the crisis resolution and anticipatory planning. Basically, did the patient reach their objectives for the nursing? Did they reach the outcome? One of the things that we want to make sure that we develop is that action plan for that patient to deal with that stressor should it occur again. Because you want them to develop those coping skills that the next time that this happens that they can come up with a situation, an answer to the situation, or make sure that they're able to cope with it a little bit better. Basically, with crisis, one of the things you want to do is to follow up 4 to 8 weeks after the initial interview. Remember, a lot of these acute crises usually only last 1 to 3 weeks anyway. But follow-up is important. Making sure that that patient is safe, making sure that they've done more adaptive ways to cope with that stress. Do they have a stronger support system? And sometimes that support system may be the healthcare system if they have no family or if they've alienated their family. Have they returned to their pre-crisis level of functioning? Sometimes that doesn't occur. But is it a functional level that you have to look at? Questions about crisis? Now I know Ms. Ward is going to talk more about like mass crisis or disasters. Yes, starting Wednesday? Tuesday, I don't know. I have a baby tomorrow after the test. But she's going to talk to you more about how you manage disasters. Now, with stress and stress-related disorders, the one that I'm going to focus on is PTSD. And I think that looking at a lot of the literature, a lot of the media, we've learned a lot more about PTSD. But one of the things I want to caution you with, guys, is that it's not just people that have experienced extreme trauma in war situations. People that have had major crises in their life, i.e. a motor vehicle accident with multi-system trauma, rape. A lot of people actually suffer from PTSD, not just our military. Okay? So PTSD is a situation that occur in a lot of people. And I think we're just starting to recognize that more and more. Chronic long-term stress can cause physiologic harm as well as emotional difficulties. And what we're starting to see is that there's a lot more impact that the stress in our lives has on our physical health. Not only post-traumatic stress disorder, but depression, cancer, heart disease, eczema or other skin disorders, stomach ulcers, a little bit, but H. pylori sort of contributes to a lot of it, asthma, colds and influenza. Why would prolonged stress impact colds or influenza? Decreased immune system. And that is one of the things that a lot of these things have, is because of that decreased immune system. Now, with PTSD, basically you've got that autonomic nervous system sort of sitting on ready, 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 okay? Where you have either the fight or flight or rest and digest. Remember, rest and digest is that parasympathetic. It chills. Whereas your fight or flight, that sympathetic nervous system, I'm ready, I'm ready, I'm ready. It's sort of like SpongeBob. I'm ready, ready, ready. What you find is with PTSD, you have a lot of innervation of that sympathetic nervous system. That fight or flight, and the parasympathetic doesn't really come into play. What you find is that you have that pituitary, hypothalamus, adrenal gland feedback loop that sort of kicks in. Basically with PTSD is that there is some stimulus or a trigger that the body is preparing for a situation that threatens survival or perceives that it threatens survival. So what you have is that the brain signals the hypothalamus stimulates the ANS, adrenals, epinephrine, ACTH, and what happens is you get increased heart rate, increased blood pressure, increased respirations, and increased blood flow. So it gets to be sort of a vicious circle. In other words, that fight or flight mechanism is on overdrive. Okay? Or hormones. Alright, so what we want to do with this stress response, whether it be PTSD or just sort of severe anxiety, is something that elicits that relaxation response. A lot of times taking a couple deep breaths may help with kicking in that parasympathetic nervous system. Sometimes physical activity. A lot of people work off their stress by running. Not me. Running is something when there's a dog after you, but that's it. Alright. Physical activity, whether it be exercise or some type of thing that will relieve your stress. Social supports, family ties, acquaintances, spouses, and friends. What I'm going to tell you is if you look in your psych book at box 10.1, hint, hint, that might give you some selected methods that would help you with stress reduction. Now, PTSD usually occurs after a traumatic event outside the range of usual human experience. What happens is that hypothalamic pituitary adrenal system has an abnormal response. Depression can occur, and if PTSD is undertreated or untreated, basically it can be extremely painful to the mental health of this patient or person. DSM-5, basically, by definition, for PTSD to be one of the diagnoses, the symptoms last 1 month or longer after the traumatic event, then it's acute stress disorder. PTSD is it's longer than a month. Let me say that again. If you have an event, symptoms last a month and go away. It's acute stress disorder. But if the symptoms persist months, years, or a lifetime, then that's PTSD. Basically, what you will see is that it can happen not only to the person that it happened to, but it can happen to their family or a loved one or someone that may have witnessed, like a knifing or a shooting, etc. Though PTSD was first brought to the public attention in relation to war veterans, we're starting to see this not only in our veterans from Iraq and Afghanistan, but we saw it in World War II or World War I, where it may have been called shell shock or combat trauma. Those were actually PTSD. They just used a different terminology for it. Probably where we started seeing the majority of it was after the Vietnam War. Okay? Other things that may cause it, other than wartime situations or what's going on in Israel and Syria right now, sexual abuse, torture, sexual assault, human disasters, natural disasters. A large number of the survivors of Hurricane Katrina experienced PTSD. Crimes, or sometimes even the diagnosis of a life-threatening illness may cause it. Again, helplessness or powerlessness are two major emotional feelings that these patients will have. What causes it, we don't know. Genetic, basically what they're saying is that they're focusing on genes that may play a role in creating memories. The latest research that I've seen is in the brain research of the amygdala. Basically, it is an area of the brain that's emotion, learning, and memory. So that these highly emotional memories may often be triggers for experiencing that extreme anxiety. Environmental factors, head trauma. One of the things that we're starting to see with the Gulf War, Iraq and Afghanistan, is that a large number of patients with PTSD also experience traumatic brain injury as well. Looking at these two areas, with if you have damage to either of these areas, the prefrontal cortex or the anterior cingular cortex, these may play a role in some of the symptoms that you see as part of those triggers. And then just prefrontal cortex. The amygdala actually is a little area right there in the forebrain. Okay? Causes, well, personality and cognitive, social factors. Basically, the availability and use of social support may be one of the causes that you see. People that don't have as good a social support tend to have higher incidences of PTSD after, like, traumatic injury, like with motor vehicle crash. Okay? Basically, when you're looking at PTSD, there are some factors that will cause the diagnosis. Re-experiencing symptoms, flashbacks are one of the things that you usually see. They relive the trauma over and over, including physical symptoms like a racing heart or sweating, bad dreams. So sleep disorders are going to be a major problem. Frightening thoughts, re-experiencing the symptoms. Things that happen in the everyday life can trigger re-experiencing. One of my cousins was in Vietnam War. He lived in Thomasville, what's very similar to this. There was a train track that ran by his house. Every time the rumble of that train would come, he would go under the bed because he thought he was getting bombed. And he did that for at least 8 years after he came back. But that rumble of that train was enough to trigger the PTSD that he experienced. Avoidance is a second sign and symptom. They stay away from places, events, or objects that are reminders of the experience. You may see them emotionally numb or depersonalize. Guilt or depression are common. Avoidance is one of the things that you see. They avoid situations that may cause those triggers. Howard moved. They changed their routine. For example, if you had a bad car accident, those people may avoid driving or riding in a car. A lot of your people that are agoraphobic, meaning they don't come out of their house, it may be due to a traumatic episode with super PTSD. Hyperarousal. These people are startled very easy. They're feeling tense or on edge. These are patients you do not creep up on. These are patients that you approach from the front. These are patients that have difficulty sleeping. They often will have anger issues as well. Those hyperarousal, because remember that amygdala is that emotional center, may feel very stressed and very angry. And violence, like with spousal or child abuse, can be a problem. To be diagnosed, they have to have one of the following, all of the following for at least 1 month or greater. 1 re-experiencing symptom, i.e. the flashbacks, 3 avoidance symptoms, and 2 hyperarousal symptoms. Okay? Children get PTSD as well. How do they react differently? Well, usually what you see with children is regression. The bedwetting, forgetting how or being unable to talk. You may see them acting out scary events during playtime. And play therapy is one of the ways that you can do an assessment to find out what happened to that child. Usually with older children and teens, you see the symptoms like you do with adults. Okay? Treatment, basically psychotherapy or talk therapy, is one of the things that you would want to do. Exposure therapy is something that you would do under the care of a psychotherapist. Basically what this does is it helps people face and control their fear. It exposes the trauma. Or basically it exposes them to the triggers that may trigger the flashback. Writing, journaling may help. But typically this is not something that you would want to do without the help of a psychiatrist or psychologist. This is not girlfriend drag them to the spot where the accident happened, because that person is not able to compensate for the extreme reaction that may occur. Other treatment, cognitive restructuring. Help them make sense of that bad memory. Sometimes people remember events differently than actually how it happened. It's like the difference between the major surgery and the minor surgery. What might seem minor to us was a major event for them. And I'm not saying you discount how they feel about that event, but sometimes you may need to help them deal with it in a more realistic manner, where it's instead of it's been blown out of proportion. Okay? Doesn't mean that the stress and the trauma that they underwent is not real. It is. But sometimes you need to help them frame it a little differently. Teaching that person how to reduce anxiety would help. Okay? And that box will tell you some of those techniques. Psychopharmacology is the treatment of choice with individuals with PTSD. When those symptoms become serious, medications can be used and help the patient gain emotional control. One of the things that you will see is to help with those flashbacks, with avoidance or numbing. Usually SSRIs or your second generation antipsychotics. They will start off with the SSRIs because they have less side effects. Remembering with your SSRIs, what kind of side effects are we going to be looking for? Dry mouth, suicidal ideation. Okay, so you got it. So remember those side effects. With treatment resistant, usually what you will find is they will go with those second generation antipsychotics. Panic attacks. A lot of times what you will see is they will use benzos for those, your Ativans, to help with that. Nightmares. Don't ask me why this cardiac drug, Minipress, works, but it does. Okay. The other thing that you will see that will help with those nightmares is a lot of times they will give them a very mild sedative to help them sleep. Okay? A lot of people with PTSD avoid sleeping because of those nightmares. And what happens is it sort of gets to be in a very vicious circle, because the less sleep that they get, the more nightmares or flashbacks that they will get. Now, acute stress disorder, typically what you will see with this, remember this is the one that lasts about a month and then it may go away. Often if you have continued exposure, it may develop into PTSD. And I have seen it in a lot in my fellow EMS workers. I'll see it a lot in police officers that are exposed to horrific child abuse cases or multiple accidents. Acute stress disorder, as I said, what you see by these intrusive symptoms, they have those obsessive thoughts, they continually go back to that situation, they may avoid call into work fairly frequently. By definition, acute stress disorder resolves within 1 month. Okay. One of the things that we do as healthcare workers to help us, and nurses can experience PTSD and acute stress response as well, especially if it's a patient that you've been working with and they die for no particular reason, is that you want to do a debriefing. What happened? What could I have done better? If I've done everything as good as I could, sometimes you have to realize that dying will occur because even though you've done the best that you could. Typically, counseling, occasional medications would help. One of the things that you'll find is that some nurses are more likely to develop what we call compassion fatigue. Compassion fatigue basically is one of those things that develops because you are so compassionate in caring for your patients, and what happens is that it's called burnout. Okay? Typically what you find is that a lot of departments and disciplines, hospice, pediatrics, emergency room, oncology, forensics, and psychiatric healthcare workers often develop that compassion fatigue or PTSD. What you will find is that as you develop your nursing skills, you will also have to find a way to cope, because not only do you need to think about what am I coping, I'm coping with taking care of this patient. I mean, every nurse's prayer is, please don't die on my shift. Okay? And that, I'm going to tell you, it's one of those things that I've said over and over, please don't die on my shift, because I don't want to be here when you go. So it's one of those things that you will have to develop coping skills with dealing with the care of these patients, because sometimes you've worked with them for months and you can get very, very attached. All right, questions?